This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Orthopaedic Surgery, published in 2026. It's titled C2 Slope as an Independent Predictor of Cervical Lordosis Loss Following Laminoplasty.
This is a topic that hits home for anyone performing posterior cervical surgery. We know that laminoplasty is a staple for treating cervical spondylotic myelopathy, or CSM, because it allows for multi-level decompression while theoretically preserving more motion and stability than a laminectomy and fusion. But, as we see in our clinics, the dreaded postoperative loss of cervical lordosis is a common and clinically relevant complication.
Exactly, Dr. Aris. The authors point out that when we lose that normal cervical lordosis, moving toward kyphosis or sagittal imbalance, patients don't just have bad x-rays. They experience exacerbated neck and shoulder pain, poorer neurological recovery, and a compromised quality of daily life.
Right. We've always looked at things like the preoperative C27 Cobb angle. Traditionally, we've thought that if the Cobb angle is less than 7 degrees, those patients are at a higher risk for postoperative kyphosis. Some people also look at the T1 slope, but the authors of this study argue that these have limitations.
They do. They mention that the Cobb angle is an intrinsic measure. It doesn't account for how the head is positioned over the thorax. And while the T1 slope is helpful, you usually have to calculate the T1S-CL mismatch to get a full picture of balance, which can be operationally complex in a busy clinic.
Which brings us to the star of this paper, the C2 slope, or C2S. Alara, how do the authors define it?
The C2 slope is defined as the angle between the C2 inferior end plate and the horizontal plane. What's really interesting from a mathematical perspective is that C2S essentially approximates the T1S-CL mismatch. So instead of measuring two different things and subtracting them, you can look at C2S as a single integrated indicator of the relationship between the upper and lower cervical alignment.
That's a powerful concept. It reflects the degree of match between cervical lordosis and thoracic inclination. If the C2S is elevated, it suggests that the cervical lordosis isn't sufficient to match the thoracic inclination. These patients are often using excessive atlantoaxial hyperextension just to maintain a horizontal gaze.
To test this, the researchers conducted a retrospective cohort study at Peking University People's Hospital. They looked at 179 patients who underwent standard open-door cervical laminoplasty between 2014 and 2020. They had a solid follow-up period too, a minimum of 24 months.
And for the listeners who want the technical details on the surgery, all patients had a posterior midline incision, subperiosteal dissection to the lateral masses, and a high-speed burr was used to create the open door on one side while thinning the hinge on the other. They used titanium mini plates for fixation, and patients wore a soft collar for 2 to 4 weeks post-op.
The researchers divided the 179 patients into two groups based on their radiological outcomes. The lordosis deterioration group was defined as those who had a loss of more than 5 degrees in their C27 Cobb angle at the final follow-up. The control group had a loss of 5 degrees or less.
So what did the numbers show?
Out of the 179 patients, 55, about 30%, fell into the lordosis loss group. When they compared the two groups preoperatively, the differences were quite striking. The lordosis loss group had a significantly higher preoperative C2 slope, 14.57 degrees compared to only 9.52 degrees in the control group.
That's a significant delta. Were there other preoperative differences?
Yes, the lordosis loss group also had a lower preoperative Cobb angle, 13.01 degrees versus 16.1 degrees, and a greater cervical sagittal vertical axis, or CSVA. Specifically, the loss group had a CSVA of 2.58 centimeters compared to 2.13 centimeters in the controls.
This is where it gets critical for our residents and fellows. We often focus on the angles, but we have to look at the patient. Did the loss of lordosis actually translate to worse clinical outcomes in this cohort?
It did. The study found that the lordosis loss group had significantly worse postoperative neck pain, with VAS scores of 3.31 versus 2.40 in the control group. They also had slightly lower JOA scores, 15.45 compared to 15.78. While the JOA difference is small, the trend toward poorer neurological recovery and increased pain is clear.
So we have multiple factors, C2S, Cobb angle, and CSVA. But the key question in any of these studies is which one actually drives the outcome. What did the multivariate analysis show?
This is the punchline of the paper. When they performed the binary logistic regression to adjust for all those conventional parameters, the preoperative C2 slope was revealed as the only independent predictor of postoperative cervical lordosis loss. The odds ratio was 1.176.
That's impressive. It essentially means that for every degree of increase in the preoperative C2 slope, the risk of losing more than 5 degrees of lordosis after surgery increases by nearly 18%.
Exactly. And for those of us looking for a specific number to use in clinic, they conducted a receiver operating characteristic, or ROC curve analysis. They identified an optimal cutoff value for the C2 slope of 11.49 degrees.
11.49 degrees. So if I'm looking at a lateral X-ray of a patient with CSM and I see a C2 slope higher than roughly 11.5 degrees, I should be concerned that a standard laminoplasty might lead to a loss of alignment.
That's the takeaway. The author suggests that C2S is a simple and effective tool for identifying these high-risk patients. It helps in optimizing surgical planning. If a patient is above that threshold, we might need to consider alignment-preserving strategies or perhaps even a different surgical approach.
It really simplifies the preoperative assessment. Instead of trying to balance the T1 slope against the Cobb angle, you look at the C2 slope as a proxy for that mismatch. If the C2 inferior end plate is tilted too far forward relative to the horizontal, the system is already under strain.
Right. And as the paper notes, an elevated C2S indicates that the patient's current lordosis isn't keeping up with their thoracic inclination. When we perform a laminoplasty, we are inevitably disrupting some of the posterior elements, the muscles and ligaments that help maintain that balance. If they are already at the limit, that disruption is enough to tip them into lordosis loss.
It's a great reminder that neurosurgery is as much about sagittal balance as it is about decompression. This study gives us a very practical metric to use.
It's also worth noting the study's strengths: a large cohort of 179 patients, a single surgeon to keep the technique consistent, and a 24-month follow-up, which is usually long enough to see these sagittal changes stabilize.
Definitely. For our listeners, students, and residents, make sure you're looking at that C2 inferior end plate on your preoperative films. Don't just look at the stenosis, look at the slope.
Well, that covers the key findings of this study. C2 slope as a simple, independent predictor of lordosis loss. It's definitely something I'll be looking for in the research moving forward.
Great summary, Alara. That's all for today's episode of the Neurosurgery Hub podcast. Thank you for joining us, and we'll see you next time.
Thank you, everyone. Stay curious.